As I said earlier, my name is Henry Hoffman. I'm an occupational therapist and the co-founder of Saebo. I started Saebo back in 2001 with our flagship product back then was the Saebo Flex. The initial goal of Saebo when we first started out was to develop, create, or identify affordable, accessible, evidence-based products for our patients. You know, it's always been a difficult situation as a therapist, I'm sure you guys can relate to it, where we have good technology that exists and we can use that technology for the most part in a clinic setting. The question is, what affordable technology exists for the patients at home following discharge? And that's always been the battle. How can we replicate what we did in inpatient at home? And I know that's where most of these gains will be made. How can we shape or position these clients for best outcomes? And that's always been the goal at Saebo. Of course, there's some equipment that we have that's too expensive for clients, but we try to weight our product offering towards the affordable side. And today will be a good conversation about that as we discuss the new SaeboMAS Mini that's going to be coming out shortly, which will be, of course, geared towards clinicians, but we do have a hardship program that patients can benefit from so they can have access to that unweighting technology. So just a little quick, let me start this presentation here. That's me. I graduated from Duval College in Buffalo, New York in 1997 with a master's degree in OT. Worked in a variety of clinical settings. Right before leaving Burke Rehab in New York is when I originally started Saebo. And so I left in 2002. My passion prior to Saebo was orthopedic medicine, non-operative manual therapy, joint-specific treatment for the upper limb. So it's been an ongoing struggle for me because I love working with neuro clients and I love my ortho clients. So I try to do a good job integrating both principles into my treatment. So basically in 2001, I left Burke and focused on Saebo. And you know, and some of you on this call, I know most of you, I consider most of you guys friends, the ones I know. And you've seen the evolution of Saebo over the years for the most part. And so you can kind of see our product line. We typically create evidence-based buckets, if you will, or categories of treatment that we can offer our clients, of course, with the goal of what can they do at home. So with today's talk, we're not going to be discussing the other Saebo product line. We're going to be mainly focusing on the SaeboMAS and, of course, the SaeboMAS Mini. And so over the years, research has made it abundantly clear that repetitions will be required in order for functional progress to be made. And following the advent of some of these products like the Saebo Flex, we learned early on that many clients were unable to perform required amount of time to get those benefits due to fatigue or endurance or pain. And so oftentimes we as clinicians, you know, we were handling the client or doing hand over hand assist or lifting the arm so we can get those much needed repetitions. But is that really practical for the clinician in the clinic to literally lift the client's arm for 45 minutes? Or think about home. Is it really practical to assume the client caregiver, maybe a 72-year-old wife, is literally going to lift the husband's arm for a 45-minute session back and forth? No, it's not practical. So what happens is, we know this story. We've seen this movie. The patient goes home with all good intentions of doing the home program that you set up. Unfortunately, after the first, second, third week, they realize how difficult it is to do their home program because of the limited movement. And then they end up failing at the program, which ultimately leads to a plateau, which is, you know, for us, the Diablo. We don't like that word, but that's what happens, and we see it time and time again. So the goal of the mobile arm support and gravity compensation and unweighting technology is how can we recreate what our hands do in the clinic for home use. Of course, in the clinic it's important because I know none of us are signing up for 45 minutes of constant lifting of a patient's arm. That would be kind of a workman's comp problem at that point. You know, get a nice work injury, if you will. So that's not the goal either. So in the clinic, the goal is clear. How can we unweight the limb so better movements can occur? Maybe decrease compensation, maybe better motor control patterns, maybe decrease the synergy patterns because we've unweighted the limb, which allows for better force coupling of movements and less compensatory movements or exertion causing more tone to kick in. Maybe it's, I have 3 patients to see. They can come down for more therapy. Let me set them up with an unweighting device so they can continue to get more therapy. As far as home use, it's pretty evident. If the patient can't move the limb successfully, how are they going to do it at home? And that's where unweighting technology is pretty obvious for home use as well. You know, the other big issue here is for some patients, it's not even that. For some patients, we notice that the only thing separating the client from performing self-care tasks is lack of proximal strength. If they only had something that could lift their arm so they could groom, brush their teeth, eat, whatever the case may be, that's all they need to get their independence. That's a functional tool. So we'll talk about remedial, we'll talk about functional. And don't forget post-operative. Don't forget post-operative clients, orthopedic clients. I remember working with a clinic where we were primarily seeing neuro patients, but there happened to be a post-shoulder replacement patient who had 8 out of 10 pain. And with 8 out of 10 pain, he could barely lift his arm. It was so guarded. This is with the therapist trying to do hand over hand for active assisted movements. But the patient's arm and the rotator cuff was so guarded that they would subconsciously fire the cuff, which caused the inflammation to kick in and the pain. So the only way we could get the pain to come down was literally, almost like they're swimming in a pool, put them in a mobile arm support to unweight the limb completely where the patient is in control of their own activation and deactivation of the cuff muscles. By unweighting the limb and the therapist not touching the patient consciously felt more comfortable with relaxing the cuff muscles. And then they were able to do their own gravity assist, active assist movements with a 2 out of 10 pain, not 8 out of 10, 2 out of 10. And it's amazing that the patients get guarded even when you're trying to help them because you don't know how much to assist, how much they need to relax. It's a very difficult marriage during that treatment program. So please don't forget about your post-op or any of your painful shoulder patients. So in a nutshell, with this brief intro, these are the reasons why we created the SaeboMAS. Now, of course, there's other unweighting devices, and we'll talk about those. But the problems and the struggles with the other ones were, they were time-consuming, they would break, they didn't give us the smoothness we needed. So we'll talk about that. But for today's webinar, I'd like to introduce gravity compensation to you. For some of you that don't know, I see a lot of people registered. And looking at the folks registered, there's a lot of people that don't currently have a SaeboMAS. So I'd like to at least educate and promote and discuss and then challenge ourselves to think, well, how could this help us? What could we do with this? How could this help our patients? So having said all that, I'd like to get started with the gravity-supported component of the presentation. And for most of you, you know that gravity-supported or weight-supported or zero gravity or gravity-compensated training they all mean the same thing. It's synonymous. It counteracts the effects of gravity while trying to facilitate or promote good normal movement. Weight-supported upper and lower body systems, they've been around for a while now. They assist patients with making more meaningful movements. When you look at gravity-supported training for upper limb, this picture is an example of a 3D printed model with rubber bands for a 2 or 3-year-old, I want to say. So it's amazing how this is a exoskeleton wearable arm support system. You can see the trunk attachment feature. This is really cool for some of these little kiddos that haven't used their arm once. And when they put this device on and their version of it, and they can start interacting with their hands for the very first time, it's amazing what the possibilities are at that point. So for upper limb task-oriented training, unloading the arm during treatment may assist in minimizing fatigue and compensation. Think about your clients. When I think about my Saebo patients, I would put them in a SaeboFlex, and I would say, okay, let's start the repetitions, get started with grasp and release. Well, guess what? After 20 reps, they're exhausted, some of these patients. They can't move anymore. Well, if I only have a 45-minute session and they're taking a break every 10 or 15 or 20 repetitions, we're not going to get through a lot of repetitions. So I can either sit them down and take a 3 or 4 minute break, or I could sit them down or stand them up and assist moving their arm, or I could have them continue doing the training with a unweighted mobile arm support so they're not so fatigued proximally. They still get the repetitions they need for cortical plasticity, and they can still incorporate their arm into treatment and finish the 45-minute sessions with less breaks. So you got to look at the fatigue factor and the compensation factor. For lower extremity gait training, I know most of us on this call are occupational therapists, but for lower extremity gait training, you're familiar with these. These are body weight supported solutions. Most of you have these in your clinic. The body weight support treatment is commonly combined with treadmill training, or you can do body weight with robotic components with the treadmill training. Patients are partially suspended in a harness, and then the lucky physical therapist of the week gets to literally bend over at the trunk or sit down and physically move the leg one step at a time for hundreds of repetitions. So whoever signs up for that, I don't know if it's the employee of the month that gets that special treatment, but the lucky physical therapist gets to continuously, manually move the patient's leg from one step at a time. So obviously that's not fun either. So I know there's a lot of new solutions out there. When I was joking a minute ago, I'm talking about some of these photos. You see the PT down below. Of course, she's smiling for the brochure photo, but I guarantee you she's probably not smiling during the clinic when she's sweating with her third patient doing the treadmill training. So clearly technology has advanced. There are better solutions now that also include robotics. But to get the idea of body weight support, here's some of the lower extremity examples. So let's talk about mobile arm supports, the purpose of today's call. Not new, it's been around for 5 or 6 decades. Gravity-supported mechanical device mounted to wheelchairs. Those are the ones that you are probably familiar with, the ones that are mounted to wheelchairs, or the ones that are tabletop display mounted. And they literally support the weak upper limb to improve function. So these devices allow patients with proximal weakness to perform self-care tasks, but they also are used for stroke patients or other types of pathologies to not only work on self-care, but to also work on improving motor recovery. And as I said earlier, it's been around for decades. Rancho Los Amigos was one of the first, if not the first, hospital to create and publish the first mobile arm support unweighting device for the upper limb for ADLs. So this is something that has been going on for many years. The purpose of the SaeboMAS was not to change drastically mobile arm support technology, just make it better. You may be familiar with some of these photos. Some of these photos are pieces of equipment that might be in your wheelchair closets right now, like it was in mine. The cable may be broken, there may be dust on it, parts may be missing. So we've all been there. These products, the problem with the mobile arm support industry is not that it started 50 years ago. The problem is that some of these products still look like they were created 50 years ago. And that's the problem. So that means they break, they're not easy to use. You need to be Tim the Tool Man and have a tool belt and make all these different adjustments. So we wanted to create something that was very quick and easy, could support a very heavy limb, especially with spasticity, frictionless, and you can transport very easily throughout the clinic. And so that's something we'll focus on. So getting back to the birth of mobile arm supports and the purpose. There's 2 purposes: compensatory or functional, and remedial. So in addition to using these mobile arm supports to perform self-care tasks so they can actually feed themselves, for example, studies also show that it's very important to use these unweighting technologies because it can improve in motor recovery and function. So it's a twofold reason for considering unweighting technology. Just to give you a couple examples, there's some studies here. Hoffman study in 2009 in RIC. 8 chronic stroke patients had limited arm and hand function. They received 18 30-minute sessions of gravity compensated reach training for 6 weeks. Before and after training, unsupported reach and the Fuglemeyer assessments were compared. And the results showed after training, the maximal reach distance improved significantly, together with also improved elbow extensions. That was good to see. Another study looked at 28 chronic stroke survivors with moderate to severely impaired hemiparesis. They were randomly assigned to 2 groups. The experimental group was the gravity-supported group. The control group was just tabletop exercise traditional treatment. The blinded examiner assessed arm movements before and after the 24 one-hour sessions and a 6-month follow-up. And again, great positive results. Gravity-supported arm exercises definitely can improve arm movement ability after these chronic severe hemiparetic patients. So that was pretty nice to see. Finally, another quick example. 7 chronic stroke survivors received 18 30-minute sessions of gravity compensation reach training for 6 weeks. During the training, they had computer-based games that were played. Before and after training, arm function was assessed with the Fuglemeyer and standardized unsupported circle drawing tasks. and the Fugl-Meyer score improved post-training, and there was significant improvement in the functional workspace movements of the hemiparetic arm, as evidenced by a normalized circle area, which is a specific test that they've used to define motor improvement. It mentions gravity compensation with computer-based games, and that's something that I see as the future. Of course, we talked about functional compensatory, self-feeding for mobile arm sports. Then we talked about improved motor recovery through task-specific training. But don't forget, there's this whole other umbrella of combination treatment with gaming and mobile arm supports. And that's an area we're focusing on, and we're dedicated to developing and making it very accessible for clients. Not only in the clinic can you start to do games with the SaeboMAS, but at home, especially with the SaeboMAS Mini and other types of unweighting devices, you can also continue to not only do self-care, not only do functional task training, but if you have clients interested in staying motivated with games, there'll be that opportunity as well. So, SaeboMAS. For the folks that are not familiar with the SaeboMAS, MAS obviously means mobile arm support, or if you're Spanish, it means more. So there's a play on words there for Saebo more. It's a zero gravity dynamic mobile arm support. It challenges the weakened shoulder and elbow during functional tasks and exercises. So the main driver with the SaeboMAS, it's a parallelogram, if you will. And at the bottom of that parallelogram is a spring. So it's spring-based. So you, the clinician, can adjust the assistance level based on the patient's needs, whether they're very weak or they're heavy, or their arm's heavy. If you want to challenge them more, then you provide more resistance by eliminating some of the spring assist. Or if they really can't move that much, then you increase the assistance by increasing the tension. It's going to lift the arm for the client. Of course, I like to combine my treatments with other modalities such as biofeedback. What a great way to incorporate the patient's ability to be aware of their own muscle activation by allowing them to have sensors on their shoulder that can give them auditory or visual feedback every time they move their arm. So I like to do biofeedback. I also like to do EMG triggered stimulation. I know you may or may not know about the Saebo-Myotract Infinity, but I love, especially for my subluxation patients, to put them in the mobile arm support because it supports the arm, approximates the humerus back into the glenoid, and then you unweight the limb, and then you can do electrical stimulation, especially EMG triggered, so they have to move first to get the stim. So while they're doing either exercises, open chain drills, or task training, they're getting stimmed. And that's a great subluxation protocol. So I like to do that as well. Now, tension scale. For the SaeboMAS, the clinic version, there's a scale from 1 to 15. 1 is the least amount of tension, 15 is the most amount of tension. So if you need to increase the tension, you can document that. If you're going out of town and you have another therapist subbing for you, then the other therapist knows exactly where you left off. Plus you can show your patient, gee, you were at 7 out of 15, now you're down to 3. It's kind of like TheraBand. The patient starts off with red or yellow or red, and then she advances to red or blue. So it's a great way to grade and document the patient's progress. Now the video may be a little delayed based on your internet speed, but I want to give you a couple examples of patients who are benefiting from the SaeboMAS. This gentleman does not need a glove or a SaeboFlex. His hand functions fine. It's okay, but he can improve on his own without technology there. But you can really see his shoulders hiking. He has very limited shoulder movement, so he's unable to complete the task. And so what we do is we assist him with the SaeboMAS, challenge him just enough where it's still challenging but successful. You don't want to make it too easy for the client. So you can see hopefully on your screen, the client has a SaeboMAS now. That one's table mounted. We also have a base frame on wheels, which is, in my opinion, better because you can take it from room to room. And you can see the difference. Another example is this gentleman's trying to, we all have this activity, it's the Velcro blocks with the little loops. He's trying to grab those Velcro blocks and transfer them. His humerus is literally just fixated to his rib cage. He has no abduction at all. It's all trunk. So I'm really excited to then put the mobile arm support on him so I can isolate new movements, activate new muscle patterns, and show him that he can activate his biceps and triceps as well. So that's another example of incorporating the SaeboMAS. Now I'm going to fast forward to the next slide. This gentleman's using the SaeboFlex, but as you can see, he can't even get that ball into a 4-inch height tube. Very, very weak proximally. It's taking 2 therapists to be there to kind of help and support him. So for me, I'm excited to get the SaeboMAS going with this gentleman because I want to see what movement he can do on his own, problem solve his own strategies. He can do it standing. He can do it sitting. So you can see here a lot of muscle firing on his own, which is great. And this last lady, she doesn't even have forward flexion. So when you unweight the arm, forward flexion exists now. There's a whole new movement pattern. And that's all because we were able to unweight that arm. Okay, I'm going to fast forward to another video. Spinal cord patients. Oftentimes we are working with these patients literally lifting their arm. This is an open chain exercise program where he is going to sit there for 20-30 minutes doing various open chain exercises to strengthen his shoulder. And as he improves, I'm going to decrease the amount of assistance needed. I don't need to be there the whole time. I don't need to lift his arm for him. I like the flexibility and the versatility that's available, so I'm happy with this program. So that's an example of just doing straight exercises. Functionally, there's many things you can do with your own mobile arm support at home or in the ADL kitchen. We have a lot of patients who have the mobile arm support for home use, but of course in your ADL kitchen in the OT gym, you can imagine what's possible maybe with the feeding group that you have in the morning or the dining group. There's a lot that's possible. Just more examples of functional tasks. Now, as I said earlier, the SaeboMAS does come with a table mount. When we first started, all we had was the table mount. We didn't have the base frame on wheels. So we still want to offer the table mount as an option just because some clinics, either because of funding or because of space, they don't really need the base frame on wheels. But please keep in mind for the folks that do have funding or do have more space, I would not recommend the table mount as your primary solution just because A, we know from history it's going to limit the utilization of this product because now everyone needs to go to one location. The second reason from a convenience standpoint, many therapists do not want to keep undoing the mount and take it to another table and remounting it. And third, you can't take it in the dining room or the patient's room or throughout the hospital. So it is quite limiting, but worst case scenario, if you need to get the table mount, obviously get the table mount, but just realize there's better options. This is the base frame on wheels. With the base frame on wheels, you can now see that you can move it from around the gym. It can assist with the dining program. You can take to the patient's room or the ADL kitchen. So it's much better. It locks, still height adjustable. Definitely the way to go if you can do it. Now, I'm going to transition to what we're really excited about is, the SaeboMAS has been around for about 3 years now. Probably a year after we launched the SaeboMAS, we knew we needed a SaeboMAS Mini. And we were going to call it the Mini Mouse, but then I started thinking about Disney, and it sounds like Minnie Mouse. So we're not doing Minnie Mouse or Minnie Mouse. So it's a SaeboMAS Mini. And the goal of the SaeboMAS Mini is a couple. The first is the pediatric clinics, the pediatric hospitals. They don't need the big clinic version, they need a smaller version. The second reason is there are some skilled nursing facilities or some feeding groups or really tiny OT gyms that may not need the clinic version. It's going to, be a big difference as far as space. Obviously serves a lot of different needs, but the small one is just enough for some of those clinics. But the biggest reason why we wanted the SaeboMAS Mini was for your patients. We wanted to be able to offer your patients something that they can use at home that's more affordable. So we're going to come up with, it's going to launch officially in about 30 days or so. We're going to come up with a hardship price out of our Saebo Cares program specifically for your patients that will be deeply discounted as a extension of our relationship with you, the clinician. This is not something that we're going to actively be promoting to patients on the internet or the web, but if you come to us and you have a patient that could really benefit, but clearly the price of the current MAS is way too much, then we'll work with your patients to find a price that's more appropriate. We're going to come up with that pricing hardship program that will be deeply discounted for your clients. That's not something we're going to advertise as the normal price. Obviously, the normal price for clinicians will be public and we'll advertise. But if you have a patient and you want that patient to have a device like this at home, we'll work with your patient just like we do with the SaeboFlex. So of course that price can't be the clinic price, or we won't be able to offer that and have the ability to offer these patients this type of discount. So this will be something that we'll have to monitor And as long as it's something that we can provide to the patient, we'll be happy to continue to do that financially. So this is the SaeboMAS Mini. Let me show you a quick video of that. I'm just going to mute this right here. The SaeboMAS Mini is a very new product. It's going to be not as powerful as the SaeboMAS. It's not going to have the tension scale from 1 to 15. It's not going to have the same range of motion that the SaeboMAS has. In fact, it'll probably be half of that range of motion. As you can see, it won't have a base frame on wheels. It's table mounted. It's literally half the size of the actual SaeboMAS. So it could fit into one of our SaeboFlex white boxes that when you order a SaeboFlex in that box that comes, it literally can fit into that box. So it's going to be half the size, it'll support half the weight, it'll do half the range of motion, but can work great for home use, and it may work great for some of your clinics that do more self-care type or tabletop type of treatment. But if you're trying to do full range of motion, full shoulder, full external rotation, if you're trying to do some exercises in standing, if you're trying to do some exercises sideline or supine, then obviously you're going to have to go with the regular SaeboMAS, not the Mini. Let me give you a quick example of the SaeboMAS Mini, and then we'll talk more about specifics. So this gentleman was at one of our clinics, and as you can see, he's using the SaeboFlex to grasp and release, which he could otherwise not do because he didn't have finger extension. But guess what? He has zero shoulder movement. So that goes back for very limited shoulder movement. That goes back to my earlier discussion. That means he's going to need a lot of rest breaks, or I'm going to have to lift his arm for him. Guess what? With the SaeboMAS, in this case the Mini, his arm is unweighted, and he's actually firing his triceps and activating his deltoid on his own. Isn't that great? So it's all volitional based. And look at his face. He's excited. He can do this on his own. It's not you, the clinician, lifting the arm where the patient has no idea what they can or cannot do. Now let's try cross-arm adduction. Here he is trying to pick up that ball and transfer it over, horizontally adduct, and he's looking at us like, you gotta be crazy. I cannot do this. And we're saying, yes, you can, okay? And it's not happening. So with the mobile arm support, guess what? He's unweighted. He can actually fire his pec. He can actually fire his triceps. And he's showing some activation of the deltoid. That is great. And of course, his face says it all. And this is a program that he can do at home. The caregiver just has to feed the ball to him. He does the rest. That's something that would not be possible without the mobile arm support. Because what would happen is he'd go home with a SaeboFlex. Hopefully his 70-year-old wife could lift his arm for him, feed him the ball, and transfer it all together at once. That would not happen. He'd be frustrated. You would be frustrated. But with the combination treatment, now he has a successful home program. So let's look at the differences between the SaeboMAS and the SaeboMAS Mini. On the left, it can support up to 11 pounds of compensation. On the Mini, that's only 7.5 pounds. The SaeboMAS is 46 inches long, where the Mini is almost 30 inches long. The SaeboMAS is 41 inches high, where the Mini is 21 inches high. The 11 pounds was the weight of the MAS, and the 7.5 pounds was the weight of the Mini. Down below, the max compensation is 15 pounds of arm support for the SaeboMAS Clinic version, where the max compensation for the Mini is 8.5 pounds. So clearly a stark difference between the two devices. The Mini is great for home use, or some of those scenarios where you do feeding groups or pediatric. If you're a clinic, I would highly recommend you continue to choose the SaeboMAS with the base on wheels and put that on your wish list. And that would be a nice solution for them. All right, wrapping up clinical benefits: increase motor control, strength, and range of motion. We want to reduce the hand-over-hand assistance by allowing the patient to take on more of an active role. Minimize compensation during functional tasks. Provide you, the clinician, with an extra pair of hands to offer more effective facilitation when needed. Provide an opportunity for the patient to perform task-specific training. You just saw videos where these clients literally would not have been able to perform task-specific training unless you were physically lifting their arm for every repetition. So that's good news about that. Safe and effective way to treat shoulder subluxation. And don't forget your ortho clients. There are a ton of ortho clients. Maybe it's the physical therapists that are working on orthopedic shoulders. Maybe it's you. But think about all those painful shoulders that are guarded, that need some of this unweighting technologies so they can actually carry on through the treatment program, decreasing the inflammation, strengthening the muscles. And I like to do manual resistance while I'm in the mobile arm support with my patient, so there's ways to do that as well. So you could always call me. We could talk about some orthopedic problem solving with the mobile arm support. that's something I'm always excited to talk about. And as far as why the SaeboMAS, think about those other photos I showed you, those other products. No more cumbersome slings, pulleys, or weights. Very quick setup time, easy to install. The graded spring assist is great for all planes of movement. It's light, it's portable, quick tension adjustments. A lot of you guys signed up for the free demo. If you have not signed up for the free demo, as a courtesy definitely to this presentation, please do so by emailing me. What will happen is we'll ship you a SaeboMAS or the SaeboMAS Mini for a 1-week trial for free, where you'll be able to, don't take my word for it, do it yourself and create your own opinion. And hopefully you'll feel the same way that 99.9% of the clinicians feel, that this is definitely a superior product worth considering. But that's why we do the free demo, because we love to get your feedback, and we're that confident that we feel that you're going to enjoy that product. So please take advantage of that, and definitely consider combining the product with other modalities like I like to do. And don't forget, you can do it in sitting, you can do it in standing, so there's a ton of things you can do there. Finally, if you want to see a bunch of videos of the SaeboMAS in action, you can go to our YouTube channel and just look at our SaeboMAS playlist, or just like us on Facebook, because we always post great videos of people using the products, or Twitter, LinkedIn, whatever your social media pleasure is. But definitely try to stay connected. With that, I want to say thank you for watching the unweighting in-service. I am going to unmute the line so then you can ask whatever questions you'd like to ask. I appreciate your patience, and hold on one second.